Already we know the etiological factors which are responsible for the RA, and now we will see pathogenesis mechanism. We have two mechanisms here, and in the end, so first we will see this mechanism, then we will see second mechanism, and in the end we will try to combine both these mechanisms. So first let us see for this first mechanism here. So environmental factors like this smoking or infection, they can cause increased bad activity, causing increased citrullation or a hypercitrullation in the lung tissues. So in the lungs, because of the smoking or the infection or both of these things, they can cause increased bad activity, and because of the increased bad activity there is a hypercitrullation there in the lungs. Plus there is a presence of a specific alleles of the HLA-DRB1 gene, or we can say the presence of the shared epitope. So we have already know with the concept of a polymorphism, and because of the polymorphism we are getting our shared epitopes. So smoking or infection increased pad activity leading to increased citrullation plus presence of the shared epitopes. What will happen? Shared epitopes, they will combine with the hypercitrullinated proteins. We have seen the whole mechanism already. Shared epitopes combines with the hypercitrullinated proteins, and these are the antigens there, present it to the immune system. So these shared epitopes, they will combine with these hypercitrullinated proteins, and they will present it to the immune system, and immune system will get activated. We have already know why it is getting activated. So immune system gets activated to produce antibodies against the citrullinated proteins. So the immune system will gets activated and it will produce the antibodies against the citrullinated proteins, and these antibodies start circulating in the blood without any symptoms of RA. See here, these hypercitrullinated proteins, they are there in the lungs, antibodies are formed, and these antibodies now they are started getting circulating in the blood without any symptom of RA. Now this has been a very important. This person, it do not have any symptom of RA, and the antibodies are now present in the serum. Okay, so these antibodies are there in the serum without any symptom of the RA. We will see that what exactly is this. Any damage to the synovial joint due to any trauma or infection results in hypercitrullation of the hypercitrullation in the joint. So for these antibodies to attack on the joint, it requires hypercitrullation in the joint, isn't that? So these circulating antibodies in the blood, they are supposed to attack on the joint, but they cannot attack without the hypercitrullation. So which factors are responsible for the hypercitrullation? See here, there could be a trauma there in the joint, or there could be the infection there in the joint that will cause hypercitrullation in the joint. And once this hypercitrullation is there, now these antibodies, they can attack the joint. So see here, this trauma or the infection of the joint, it acts as a trigger for the circulating antibodies. Why? Because trauma and infection, it is going to cause the hypercitrullation in the joint. So it acts as a trigger for the circulating antibodies to attack the citrullinated proteins in the joint. So now this citrullinated proteins, they will get attacked by these antibodies because of the hypercitrullation mechanism there, and that will leads to the inflammation of the synovial joint, and we are getting a rheumatoid arthritis there. So in whole this process, if you see, first of all there is a hypercitrullation in the lungs, and there this is leading to the formation of the antibodies. these antibodies are circulating in the plasma there, and these antibodies, they will attack the synovial joint. Once this synovial joint is getting any trauma there, once the synovial joint is getting any infection there, that is resulting into hypercitrullation in the joint, and then these circulating antibodies, they are attacking these hypercitrullinated proteins there, and they are causing the inflammation of the joint. We are getting a disease what we call as rheumatoid arthritis. So this has been a one mechanism there. We will see the another mechanism, and then we will try to combine both these mechanisms. Now see here this second mechanism. Here the initial story is the same. So these environmental factors like this smoking, infection, they will cause increased pad activity, it will cause hypercitrullation in the lungs, and there will be a presence of specific alleles or a presence of a shared epitope. We also seen that the shared epitope, it combines with this hypercitrullinated protein to present it to the immune system. The immune system is getting activated to produce the antibodies against the citrullinated proteins, and these antibodies, they are starting circulating in the blood and remains in the blood without any symptom of the RA. So till this point the story is the same one. Now see here, these antibodies then attack already present citrullinated proteins in the joint because of the molecular mimicry, without which results in the initiation of the inflammation. So in the first mechanism, it is a trauma or the infection which is causing the hypercitrullation in the joint, but in this mechanism, see, these antibodies then attack already present citrullinated proteins. So we know that these citrullinated proteins, they are citrullinated proteins here means the physiologically produced citrullinated proteins, they are already present in the joint. Okay, so citrullinated proteins like this vimentin, then this fibrin, then this alpha enolase. These citrullinated proteins which are there in the lungs, same citrullinated proteins, they are present in the joint, but here they are the physiologically citrullinated proteins, but because of the molecular mimicry, these antibodies which are circulating in the blood, these antibodies, they attack these physiologically formed citrullinated proteins because of the molecular mimicry. And this initiates what? This initiates the inflammation here, and because of this inflammation, it results into hypercitrullation in the joint. Okay, so this inflammation triggers the process of the hypercitrullation in the joint, and again these antibodies comes and they again attacks these hypercitrullinated proteins, and the cascade is formed, and this is how in the end we get the inflammation of the joint and the RA. So from here to here, that is the antibodies, they are circulating in the blood, remains in the blood without symptom of the RA. It remains the same as per the first pathogenesis we have seen, and here what is happening is these antibodies then attack the already citrullinated proteins, already present citrullinated proteins in the joint because of the molecular mimicry, that is causing initiation of the inflammation. That is, this inflammation is triggering the process of the hypercitrullation in the joint. More ACPA arrives and attacks these citrullinated proteins, causing increased inflammation, and thereby we are getting a disease, rheumatoid arthritis. So in the first mechanism, it is the infection of the joint and inflammation of the joint. It is the infection of the joint and a trauma to the joint is responsible for the inflammation of the joint. Here we are getting the inflammation because of the molecular mimicry. isn't that? Because of the molecular mimicry, these antibodies which are circulating in the plasma, they are attacking these physiologically formed citrullinated proteins. It is causing the inflammation of the joint, and it is this inflammation is causing the initiation of the hypercitrullation in the joint, and this hypercitrullation ultimately we are getting inflammation of the joint and we are getting the disease rheumatoid arthritis. What is the difference between first and the second mechanism? There is a very little difference. Up to this antibody formation and this circulating antibodies in the plasma, the same thing is here. In the first mechanism, it is the infection of the joint, and it is a trauma to the joint which is causing the inflammation, and in the second mechanism it is because of the molecular mimicry. These antibodies, they are attacking these physiologically citrullinated proteins in the joint, responsible for the inflammation here, and in the end this initial inflammation is leading to hypercitrullation, and these more acipase arriving at this site, they are attacking these hypercitrullinated proteins, and thereby we are getting this rheumatoid arthritis. Now we will try to combine both these mechanism in the next. Now see here we have combined the first and the second mechanism. So antibodies are present in the serum even before any symptoms of RA. Until that, in both these mechanism, same story is there. Circulating antibodies do not attack the joint unless there is a hypercitrullation. So for these circulating antibodies to attack over the joint, it requires there should be hypercitrullation in the joint. Hypercitrullation in the joint can occur because of inflammation due to following reasons. So this mechanism of hypercitrullation in joint, it occurs because of the inflammation in the joint, and this inflammation in the joint can be because of these three reasons here. There could be a trauma to the joint, there could be infection of the joint. So as far as this trauma and infections are concerned, it is because it is there in the first mechanism there. Okay, so this trauma to the joint and infection to the joint is according to the first mechanism we have seen with rheumatoid arthritis. Antibodies may attack physiologically citrullinated proteins because of the molecular mimicry. So in the second mechanism we have seen that these antibodies, they attack the physiological citrullinated proteins because of the molecular mimicry. So this inflammation in the joint, according to the first mechanism, it is because of the trauma and infection, and according to the second mechanism, this inflammation of the joint we are getting because these antibodies are attacking these physiologically citrullinated proteins there. Now see here. So here we have just combined with both this mechanism. Now see here, in short we will see hypercitrullation in the lung. So in both these mechanism there is a hypercitrullation in the lungs, and this hypercitrullation in the lungs, it is leading to circulation of the antibodies in the serum. So it is causing antibodies it is producing the antibodies, and these antibodies, they are now circulating in the serum. Hypercitrullation in the joint. So which is the next event? There will be hypercitrullation in the joint. We have seen how which are the reasons which are responsible for the hypercitrullation in the joint. Antibody attacking the joint resulting in RA, and then these antibodies which are circulating in the serum, they attack the joint resulting in the RA. Okay. So here we have combined both this mechanism, and here we have just explained this mechanism in a very short manner. Hypercitrullation in the lung, this is the first event occurring in the rheumatoid arthritis. Then circulating antibodies in the serum, this is the second event we can see. Third event is the hypercitrulination in the joint, and the fourth event is these antibodies are attacking the joint, resulting into rheumatoid arthritis. In the last session, we have seen a definition of the rheumatoid arthritis. We have seen various etiological factors, those are responsible for the rheumatoid arthritis. And we have also seen how these etiological factors, they activates the immune system, which leads to the generation of the autoantibodies. These autoantibodies start circulating in the blood, and finally these autoantibodies they attack the synovial membrane in the joint, and we get the symptoms of the rheumatoid arthritis. Now this model that the disease is started in the lung basically. So see here, lung first hypothesis, this model we have followed. So lung first hypothesis, it is a major model for the rheumatoid arthritis hypothesis. Now why we are discussing this? Because there are certain other sites where this disease can start. So we have seen that how this disease is started in the lung, how this smoking and how the other etiological factors they have caused this disease. But there are certain other sites also, we will see those things also. So other mucosal sites like gums and GI tract, okay. So gums and GI tract, these are the two other mucosal sites other than lung, I mean, where this disease can be started. So these gums, usually these periodontal infections like P. gingivalis infection, it can lead to the beginning of the disease in the gums. And also this GI tract infection, various GI tract infection, they also can cause the beginning of this disease in the mucosa of the GI tract. So these two sites, gums and GI tract, these sometimes may be involved in this mechanism of the rheumatoid arthritis. Then this joint first initiation, there is one more theory, joint first initiation. In this particular category, immune response directly started in the joint without any shift from the extra-articular side. So we have seen that here the disease, it is started in the lung, or it may be started in the gums, or it may be started in the GI tract. So hypercitrulination occurred, antibodies are formed, and antibodies are already circulating in the blood, isn't that? And these antibodies which are already circulating the blood, because of the hypercitrulination process in the joint, they are going to attack the synovial membrane, isn't that? This joint first initiation, in this particular category, this immune response directly started in the joint. So hypercitrullinated proteins, they are formed in the joint, and the immune response, that is antibodies, are directly formed against the citrullinated proteins in the joints. In these three situations, in the lungs, in the gums and in the GI tract, these antibodies which are formed, they are already circulating in the serum. But in this category, these antibodies they are formed in response to the hypercitrulination. They are not already present in the blood. So this is the difference. Here the antibodies are already present in the blood and they are acting against the hypercitrullinated proteins in the joint, and here these antibodies are not existed in the blood initially, they are formed in the response to the hypercitrulination in the joint. So there is a direct involvement of the joint in these cases. So this hypothesis we call as the joint first initiation. Then lastly, a very interesting one, seronegative RA. See here, patient presented with classical symptoms of RA. So In this particular situation, we are getting a patient with all the classical symptoms of the rheumatoid arthritis, but when we are sending the blood for these antibodies, which antibodies? Anti-citrullinated protein antibodies or anti-CCP antibodies and RF antibodies. Both these antibodies, we get that they are absent in this patient. So, this patient where all the classical symptoms of the rheumatoid arthritis are present without any presence of the antibodies in the serum, we called as a seronegative RA. So, it does mean that there must be some other mechanisms also by means of which patient is getting the symptoms of the rheumatoid arthritis. And usually in this patient, sometimes what we call as a anti-CAR-P antibody or anti-carbamylated protein antibodies, this patient are found positive with the antibody. So, it could be possible that it's still been an autoimmune disease, but the antibodies, we may not be knowing the antibodies or the factors which are producing the disease, but these anti-CAR-P antibodies many of the times will be present almost 1/5 of the patient with this seronegative RA. So, we should have some basic knowledge of these things. So, I have highlighted these points here. Inflammation of the synovial membrane is a very important event in the pathogenesis of the rheumatoid arthritis. So, see here, these antibodies, that is anti-citrullinated protein antibodies and the rheumatoid factors, these two antibodies, we know that they are already circulating the blood. We have seen the process, and these antibodies, they attack the citrullinated proteins in the synovial membrane and in the synovial fluid, and it leads to the inflammation of the synovial membrane. So, this inflammation of the synovial membrane, what we call as a synovitis, this synovitis is also causing localized tissue inflammation like ligaments, tendons and bursae. Okay. So, these antibodies, they have attacked this synovial membrane. They are causing the inflammation of the synovial membrane, that is synovitis is there, and this synovitis, because these ligaments, tendons and bursa, they are in the close proximity, and therefore also the inflammation of the ligament, tendons and bursa is there. So, synovitis is responsible for the inflammation of the ligament, tendon and bursa, and it is leading to these symptoms here: pain and tenderness, symmetrical swelling and the early morning stiffness. So, pain and tenderness of the joint, then symmetrical swelling of the joint. So, joint on both the sides are involved, and the early morning stiffness, which usually lasts for 30 minutes to 1 hour. So, these clinical features we are getting with this synovial membrane inflammation. These changes we are getting earlier in the disease, we call them as early changes, and in these early changes, distal joints are usually involved first. When I says that the distal joints are usually involved, means small joints of the hands and feet. When we are talking of the small joints of the hands, then this MCP, metacarpophalangeal joint, PIP means proximal interphalangeal joints, they are involved first in this disease, or they are the specific joints which are involved as far as the distal joints are concerned. And this MTP, if the joints of the feet are involved, then it is a metatarsophalangeal joint. Okay. So, MCP, metacarpophalangeal, PIP proximal interphalangeal joint and MTP metatarsophalangeal joints. These two, this metacarpophalangeal and proximal interphalangeal joint, they are the joints which are involved usually first in this disease process. As compared to MTP, this MCP and PIP, they are the most common one as compared to MTP. So we will see the details of this later on, but at the moment what we should know is these small joints of the hands and the feet are usually involved first. And when we say small joint, meaning what? Metacarpophalangeal joints and proximal interphalangeal joints of the hands, they are the most common involved, and also there may be the involvement of the metatarsophalangeal joints. Before we could proceed, we will see one X-ray here, so that our concept of metacarpophalangeal proximal interphalangeal joint will be clear. So let us see one X-ray here first. And here we have the metacarpals 1, 2, 3, 4, 5. Here we have a thumb, and in each fingers we have here 3 bones, phalanges rather, this proximal phalanx, middle phalanx and the distal phalanx. Here also we have a proximal phalanx, middle phalanx, distal phalanx, like that in both these fingers. And in the thumb we have only 2 phalanx here. The joint between these metacarpal and the first phalanx we called as a metacarpophalangeal. So here we have a metacarpophalangeal, here again we have a metacarpophalangeal, here also, and here also we have a metacarpophalangeal joint. The joint between the first phalanx and the second phalanx we called as a proximal interphalangeal joint. So here we have a proximal interphalangeal, here again we have a proximal interphalangeal, here also and here also. And the joint between the second phalanx and the third phalanx we called as a distal interphalangeal joint. So here we have a distal interphalangeal, here we have a distal interphalangeal, here also and here also. In the thumb we have only 2 phalanges here, and therefore in the thumb we have only one, that is interphalangeal joint. Okay. So here we have only interphalangeal joint. In the rheumatoid arthritis, what we have seen is metacarpophalangeal joints are involved and the proximal interphalangeal joints are involved. So see these metacarpophalangeal joints, these joints are involved in the rheumatoid arthritis, and also the proximal interphalangeal joints are involved in the rheumatoid arthritis. So your concept must be clear. Okay. So it does mean that when we say that metacarpophalangeal and this proximal interphalangeal joints are involved, it does mean that these distal interphalangeal joints, they are spared in the rheumatoid arthritis. This distal interphalangeal joint, they are spared in the rheumatoid arthritis. Now one more thing, this interphalangeal joint of the thumb, it is also been commonly involved with the rheumatoid arthritis. Okay. So the message is, in rheumatoid arthritis, the small joints of the hand are commonly involved. When we say small joints are involved, means the metacarpophalangeal joint and the proximal interphalangeal joint, and this DIP, that is distal interphalangeal joints, are not involved, they are spared in rheumatoid arthritis. So that's, I think your concept will be clear here. You should not have any doubt regarding this. Now we will see late changes of rheumatoid arthritis. In the late phase of the disease, the important event occurring is a destruction of the cartilage and a destruction of the bones. So this destruction of the cartilage and destruction of the bone, it is occurring in the late phase of the disease or once the disease achieves its a chronic stage. So in the chronic stage, this has been an important event, and the destruction of this cartilage and the destruction of the bone, finally the patient is presented with various type of joint deformities like a SWAN neck deformity, like a BOUTONNIERE deformity or a subluxation. So we will see the meaning of these terms later on in the lecture, but the important thing is in the late stage of the disease or a chronic stage of the disease, there is a destruction of this cartilage and a destruction of the bone. It is leading to the joint deformities. So in the early phase or early stage or acute stage of the disease, we can say there is a inflammation of the synovial membrane. Various events are taking place in the inflammation of the synovial membrane, and this inflammation of the synovial membrane is a important event in the acute phase of the disease. And once the disease achieves its chronic phase, in the chronic phase, this inflammation of the synovial membrane and various events occurring in the joint because of this inflammation of the synovial membrane, these various events, they finally leads to destruction of the cartilage and the bones, and the patient presents with a various kind of a joint deformities. So our concept must be clear in the sense that in the early phase or acute phase of the disease, it is a synovial membrane inflammation and subsequent event which are occurring because of the synovial membrane inflammation, and in the chronic phase of the disease or chronic stage of the disease, these various events in the synovial membrane, they are leading to destruction of the cartilage and the bones. Finally, we are getting joint deformities with these patients. Now here we will see various events those takes place in the inflammation of the synovial membrane. This synovial membrane, we know that it is getting inflamed because of the antibodies which are formed, these ACP antibodies and rheumatoid factors, they are attacking the citrullinated proteins in the synovial membrane and synovial fluid, and thereby they are causing the inflammation of the synovial membrane. So this synovial membrane is getting inflamed, what we call as the synovitis. Then next event is the synovial hyperplasia. There is an increase in the thickness from 1 to 3 cells to 8 to 12 cells due to proliferation of the synoviocytes. So this inflamed synovial membrane, it is getting increase in the size or getting the increase in the thickness of the synovial membrane because of the proliferation of the synoviocytes. We know that we have two types of cells there, type A cells which we call as a macrophage like, and a type B cell which we call as a fibroblast like. So these two cells, they undergo the proliferation, and now why they undergo the proliferation here? It is because these inflamed synovial membrane, these inflammatory cells, they are secreting cytokines, various types of cytokines like this TNF alpha, this interleukin 6, interleukin 17, and they are stimulating this proliferation mechanism, and that is why the synovial membrane is getting proliferated. So synovial inflammation, and this synovial inflammation, it is leading to the synovial hyperplasia. Now see this one more event, that is angiogenesis, occurs within the synovial membrane to support hyperactive tissues contributing to the swelling and warmth of the joint. So this angiogenesis, why it is occurring angiogenesis? Because what we have seen, these synovial membrane cells, they are getting proliferated and because of the proliferation, the number of cells they are increasing, and therefore the metabolic demand is increasing, and so as to fulfill this metabolic demand, angiogenesis occurs in the synovial membrane, and it is contributing to the swelling and the warmth of the joint. Then next is an increased synovial fluid. This inflamed membrane, it produces excessive synovial fluid. So these cells are inflamed, and because of that these cells, they are secreting more and more amount of synovial fluid, which is causing increase in the amount of the synovial fluid in the joint. And next is a PANNUS formation. Now this event is a very important one. Now all these event, if you see basically this first of all there is a synovial membrane inflammation, and this hyperplasia, angiogenesis, increase of synovial fluid, all these events are running there simultaneously, and lastly we are getting with a PANNUS formation. Now what is PANNUS formation? The understanding the PANNUS is very important in rheumatoid arthritis. See here, it is a protrusion. PANNUS, it is a protrusion, fibrovascular. It is a fibrovascular protrusion arising from the thickened synovial membrane. It is arising out of a thickened synovial membrane. So we know that synovial membrane, it is a hyperplastic synovial membrane there, and it is a protrusion which is arising out of this thickened synovial membrane that grows to invade the joint surface. So this thickened protrusion, this thickened tumor-like mass, we also it causes a benign tumor-like mass or benign tumor-like protrusion, which grows to invade the joint surface. It is entering into the joint surface and it is invading cartilage and bones. It invades both this cartilage and the bones and releases the enzymes. It is releasing the enzyme. A very important enzyme is a matrix metalloproteinases, MMP, what we called, causing the destruction of the cartilage and bones. So this PANNUS, which is a protrusion, it is arising from the thickened synovial membrane, and this PANNUS, it is going to invade the joint surface or a joint space, we can say. It is invading the joint space, it is invading the cartilage, it is invading the bone. Now when we say invading, means this cartilage and bone, it is coming in a physically contact with his cartilage and bone. This PANNUS, which is a protrusion from the synovial membrane, it is coming in physical contact with the cartilage and the bones, and this PANNUS, it is rich in the fibroblast. This PANNUS, it is rich in the fibroblast, and this fibroblast, we know it secretes matrix metalloproteinases, and this enzyme is very important for the destruction of the cartilage and bone. This enzyme, it causes the destruction of the cartilage and the bone. So now see what is the what is the histological difference in between this hyperplastic synovial membrane and this PANNUS. So grossly there is not much difference between the two. Only thing is, in the PANNUS the concentration of the cells is more as compared to that in the hyperplasia. Okay, so in the PANNUS the concentration of the cells is more, and especially the cells fibroblast, which secretes this enzyme MMP, their concentration is more in the PANNUS as compared to the hyperplastic synovial membrane. So this PANNUS formation is a very important stage in the rheumatoid arthritis development, and basically in the beginning only we have seen that in the phase 1 this synovial membrane inflammation, and in the late stage once the disease becomes chronic, what is important is a destruction of the cartilage and a bone. And why we are getting the destruction of the cartilage and a bone? It is because of this PANNUS. And PANNUS is what? PANNUS is nothing but a protrusion which is arising out of the thickened synovial membrane, and this PANNUS it is invading the joint space there, this invading this cartilage there, and it is invading the bones there, and thereby it is causing the destruction of the cartilage and the bones there. So this PANNUS formation is a very important event in rheumatoid arthritis, and because of this destruction of the cartilage and the bones, so we have also seen that finally it is leading to what? It is leading to various kind of deformities like SWAN deformities, BOUTONNIERE deformities, subluxation. We will see that later on. And the symptoms related to synovitis we already know: pain and tenderness of the joint, this symmetrical swelling of the joint, morning stiffness which lasts for 30 to 60 minutes. We know all these things. So, from the inflammation of the synovial membrane, which is because of this antibody attack on the citrullinated proteins in this membrane and in the synovial fluid, then it leads to synovial hyperplasia, angiogenesis, increases synovial fluid. All these events are taking place, and in the end we are getting a pannus formation, which is causing the destruction of the cartilage and the bones. Here in this image we will see some basic structures involved in the joint, and then we will go for the pannus, how the pannus looks like and how the pannus does the destruction of the cartilage and the bones. So, this is a basic image here. See here, these two bones here which are involved in this joint, and here we have a articular cartilage which is covering the ends of the bone here. So, here we have a articular cartilage, and this in the red we have a synovial membrane, and this is the joint space here, and which is filled with the synovial fluid. Then here we have a one more diagram. This again, here we have a normal joint. You can see this is the synovial membrane here, this thin layer, and here we have joint space which is filled with the synovial fluid. These are the two bones which are the part of this joint, and here we have a articular cartilage also. So this is the image of the normal joint. So now see here, this image is concerned with the synovitis, and here we have a synovial membrane inflammation, and this synovial membrane is thickened. So this image is showing hyperplastic synovial membrane, increase in the thickness of the synovial membrane. So if you compare this thickness with the normal image here, here we have a thin synovial membrane here, and here the synovial membrane is thickened, and this articular cartilage, which is a normal one here. If you see this articular cartilage here, there are some erosions there, isn't that? So you will see the erosions very clearly. I think you can see now. So here we have erosions here in the articular cartilage, and normally if you compare with this, you can see smooth surface here, but here you will see the rough surfaces because of these erosions. Now see here, this image we are trying to showing this pannus here. See here you can see this growth here which is coming out of this synovial membrane. So this synovial membrane is thickened, and this growth is arising of this synovial membrane, and it is nothing but a pannus. Okay. So here we have a pannus, and which is coming in a physical contact with this cartilage and bone, and it is causing destruction of the cartilage and the bone. This synovitis when there is a synovial hyperplasia stage there. In this synovial hyperplasia stage, there is a initial destruction of the cartilage there, and also it causes the osteoporosis of the bones. But once the pannus is formed, there is a further destruction of the cartilage, and there is a destruction of the osteoporotic bone. So we will see these things in the next notes, but for the moment what is important is in the when there is a synovial hyperplasia, there starts the destruction of the cartilage, or what we call as a initial destruction of the cartilage. So in the synovitis stage or hyperplastic synovitis, we get initial destruction of the cartilage as well as we get osteoporosis of the involved bone. And once the pannus is formed, this pannus does the further destruction of the cartilage. So here the cartilage is already started destruction, but the further destruction is done by this pannus, and these osteoporotic bones, already these bones are osteoporotic here because of the synovial hyperplasia, and now this pannus can easily destroy them. Why? Because the bones are already weakened because of the osteoporosis. We will see that in the next slide, but for the moment just remember this. See here, I have got another image here which will give quite a clear idea. See here, this side, so this is the vertical line here. So you have to look at this side because this side is concerned with the rheumatoid arthritis and this has been concerned with the osteoarthritis. So see here on this side. So this is the thickened synovial membrane we have. You can see the thickness of the synovial membrane, and here we have a projection which is arising out of this thickened synovial membrane. You can see this projection here, and this we call as a pannus. So in this diagram the things are more clear. So this is the pannus we have, and it is invading the joint space here. Sooner this pannus will grow more and it will get in contact with this cartilage, and it will start the destruction of this cartilage also. And once the cartilage destruction is over, it will also invade the bone. So once the bone surface is exposed, it will also invade the bone. So this pannus which is formed here, this pannus, we know that it is a Latin word. Pannus means a cloth, and its structure, it looks like a cloth there, isn't that? And this cloth like structure, or it is a projection which is coming out of this inflamed synovial membrane or hyperplastic synovial membrane rather, this is going to invade this joint space, and again it is going to grow more and it is going to invade the cartilage, and in the end also it is going to invade the bone also. So the pannus formation event is a very important in the rheumatoid arthritis. So look here, now we will see the various stages of the rheumatoid arthritis. So stage number 1, which I have labeled as a early RA, in this stage there is a synovitis without any destructive changes on the X-ray. So in this stage number 1, we have a synovial membrane inflammation. We know that how the synovial membrane is inflamed because of the antibodies which are formed in this disease process. They are attacking the cellulose proteins here. It is giving rise to the immune reaction, and because of this immune reaction there is an inflammation of the synovial membrane leading to synovitis. In this stage only the synovial membrane is inflamed. There are no destructive changes or positive findings on the X-ray. Then stage number 2, see here, initial cartilage damage and the osteoporosis. So in stage number 2, we get initial cartilage damage and osteoporosis. So let us try to understand how we get initial cartilage damage and how we get osteoporosis in this stage. Persistent inflammation. So this synovial membrane is already inflamed because of the immune reaction, and this inflammation is a persistent one. So persistent inflammation of this synovial membrane, it is causing cytokines like TNF alpha, interleukin 6 and interleukin 17, and also the enzymes like the matrix metalloproteinases. We know that in this synovial membrane we have two types of cells, type A cell and a type B cell. Type A cell we call as a macrophage like cell, and type B cell we call as a fibroblast like cells. So macrophage like cells and fibroblast like cells. So these macrophage like cells they secretes these cytokines. So type A cell which we called as a macrophage like cells they secretes cytokines like this TNF alpha, interleukin 6 and interleukin 17. And a type B cell which we called as a fibroblast like cells they secretes enzymes like matrix metalloproteinases causing early damage to the cartilage. So these cytokines and these enzymes they cause early damage to the cartilage. They cause this word is very important, early damage to the cartilage because of these cytokines and because of these enzymes. So this is the first thing regarding this stage. Now let us see the latter part. Also cause increase in the bone resorbing osteoclast. These cytokines and these enzymes they also results in increased bone resorbing osteoclast and decreased bone forming osteoblast. So there is an increase in the bone resorbing osteoclast and there is a decrease in the bone forming osteoblast and that results into osteoporosis. Okay. So here because in osteoporosis what we know there is a decreased density of the bone there. So because there is an increase in a bone resorbing osteoclast and decrease in a bone forming osteoblast, it leads to the osteoporosis. So in this stage number 2 which we have labeled as the initial cartilage damage and the osteoporosis, we are getting two things. One is the initial damage to the cartilage and second one is there is a osteoporosis also. Now we will see the stage number 3, further cartilage damage and bone destruction. So in stage number 3 we have a further cartilage damage. Why further cartilage damage? Because initial cartilage damage is already taken place in the stage number 2 and here the further cartilage damage you are getting in the stage number 3 and also the destruction of the bone. Now let us try to understand how exactly the things are going there. In this third stage the very important event, that is a PANNUS formation, is taking place. Okay. So we are getting a formation of the PANNUS in the stage number 3 here, and PANNUS is formed which is rich in cytokines and enzymes. Okay. So this PANNUS we knows that it is a part of a already thickened synovial membrane and it is a projection which is coming out of a already thickened synovial membrane, and this hyperplastic synovial membrane is already containing this lots of inflammatory cells, macrophage like cell or type A cells, and lots of type B cell also, what we call the fibroblast like cells. And we know that these type A cells or these macrophage like cell they secrete cytokines, and this fibroblast like cell they secretes what? They secretes enzymes. They are more in number in a hyperplastic synovial membrane, but in a PANNUS the concentration of these cells, macrophage like cells and fibroblast like cells, it is more than that in the synovial hyperplastic synovial membrane. So in the PANNUS the concentration of these cells is more than in the hyperplastic synovial membrane. So because of that the cellular concentration is more, because of that they are going to secrete more cytokines because more number of macrophage like cells and more this MMP or more enzyme because of the more concentration of the fibroblast like cells, and it invades a joint space. So this PANNUS which is formed, what it does, it invades the joint space, cartilage and the bone. We already have seen the diagram. We will go again for that diagram in a few minutes. So it invades the joint space. We have seen that it invades the cartilage once it is more grows more, and also the bone like a benign tumor. Okay, so this growth of growth or out this what we call as a this projection which is coming out of this synovial membrane, this growth is acting like a benign tumor. It is not only invading the joint space, but also it is invading the cartilage and the bone, and it causes further destruction of the cartilage. So, this PANNUS, it is causing further destruction of the cartilage, because already early cartilage damage we have here in the second stage because of the cytokines and because of the enzymes which are secreted by the cells. Now, here this PANNUS, now what is different with the PANNUS? So, already we have said that this PANNUS, the concentration of the cells in the PANNUS, it is more than that in the hyperplastic synovial membrane. Not only that, this PANNUS, it is physically getting in contact with the cartilage and the bone. So, this projection which is coming out of this thickened synovial membrane, it is making a physical contact with this cartilage and bone and pouring all these cytokines and all these enzymes into them, and thus it is causing a massive destruction of the cartilage and the bone. So, the important thing with the PANNUS is it not only it is containing a higher concentration of these type A cells and a type B cell, or these macrophage like cells and the fibroblast like cells which are secreting cytokines and the enzymes respectively, but also this PANNUS, it is making a physical contact with this cartilage and bone, and by making this physical contact it is pouring all these cytokines which are abundant in number, all these enzymes which are abundant in number, and is causing a massive destruction of the cartilage and the bone. Now, one more thing here, that this bone which are involved in these joints, they are already weakened because of the osteoporosis. In this stage 2, we have seen that these involved bones in the joints, they are already weakened. Why? Because we have seen that there is an increase in the bone resorbing osteoclast and decrease in the bone forming osteoblast. So, these bones are osteoporotic, and because of the osteoporosis, these ends of the bones are already weakened, and these weakened osteoporotic bones, because of this abundant amount of these cytokines, abundant amount of the enzymes, they get destroyed here. There is a destruction of this bone here. So, in the stage number 1, we have purely been a synovial membrane inflammation. In the stage number 2, we can say that here we have a hyperplasia. Okay? Hyperplasia of what? Synovial membrane. So, in the stage number 2, there is a hyperplasia of the synovial membrane, and in the stage number 3 of this arthritis, rheumatoid arthritis, we have a PANNUS formation. So, synovial membrane inflammation, synovial hyperplasia, and the PANNUS formation. Okay. So, whatever the information we have seen few minutes back with various events of the synovial membrane, we can now correlate like this with these stages of the rheumatoid arthritis. So, synovial membrane inflammation, this is stage number 1. Synovial membrane hyperplasia, it is a concern with stage number 2. When we say synovial membrane hyperplasia, then also this angiogenesis is also been a part, increase in the synovial fluid, that also been a part of this stage of the rheumatoid arthritis, and the PANNUS formation, it is concerned with stage number 3. Now, let us see stage number 4, that is a end stage. Extensive loss of the cartilage and the bone leads to ankylosis. So, ankylosis is nothing but a fusion of the bone. So, the bones which have been involved in the joint, they are getting fused because of the extensive loss of the cartilage and the bone, and that we call as a ankylosis. And this ankylosis results in a complete loss of a mobility of the joint. So, there is a complete loss of a mobility of that joint in the stage number 3 of stage number 4, or what we call as a end stage. Okay. So, this is how we can correlate the previous information with these various stages of rheumatoid arthritis. Already we know that metacarpophalangeal joint, proximal interphalangeal joints and the metatarsophalangeal joints, they are involved in the early stage of the rheumatoid arthritis or the acute stage of the rheumatoid arthritis, more likely to be involved. And in the late stage of the disease, as the disease progresses, it may involve the other joint. So what I have said is a centripetal joint involvement pattern we get, and centripetal joint means what? Distal joint involvement is a very common with the rheumatoid arthritis, and of this distal joint, these metacarpophalangeal, proximal interphalangeal and metatarsophalangeal, these are the joints which are more likely to be involved. And this involvement is very importantly bilaterally symmetrical. Okay, so there is a bilateral symmetrical involvement we usually gets with the rheumatoid arthritis. So see here, metacarpophalangeal joint, proximal interphalangeal joint, metatarsophalangeal joint and the wrist, they may be involved earlier in the disease. So early involvement, we have taken the joint, wrist, metatarsophalangeal, metacarpophalangeal and the proximal interphalangeal joints. In the late involvement of the disease, see, knee joint, elbow, ankles, shoulder, hip joint, those we take in the late involvement of the disease. There are exclusions there, we will see that, but these are the joints which are more likely to be involved once the disease is achieving its chronic phase. Here, this temporomandibular joint and atlanto-occipital joint, they are also, we have seen that they also may get involved in this disease process. Temporomandibular joint, TMJ, and the atlanto-occipital joint, atlanto-axial joint, they also may be involved. Now here in this pocket, if you see, just we have tried to compare MCP with the MTP, metacarpophalangeal joint, with the metatarsophalangeal joint. See, this metacarpophalangeal joint, as far as frequency of the involvement is concerned or early stage involvement is concerned, almost 70% of the time metacarpophalangeal joint is involved as compared to the MTP. MTP, it is 30% there. So if you compare in between these two joints, the involvement of the metacarpophalangeal joint in the early stage of the disease is more likely, and if you compare that with the late stage, then almost 90% of the time the involvement of the metacarpophalangeal joint is there, whereas this MTP, it is almost 85% of the time. When I say late involvement means what? The disease may be started in the other joint, and once it becomes a chronic, it is causing the involvement of the metacarpophalangeal joint or a metatarsophalangeal joint, isn't that? And this finding, these radiological erosions, radiological erosions are slow with the MCP and they are fast with the metatarsophalangeal joint. So erosions means what? The damage to the cartilage or damage to the bones that we are getting in the X-ray findings or other things also. Those are very fast with the metatarsophalangeal. Why? Because of the weight bearing. Okay, these are the joints which are concerned with the weight bearing metatarsophalangeal, and that is why the damage in this joint is fast as compared to the metacarpophalangeal joints. Now these figures, this percentage which I have mentioned, they are different in different studies there, because different group of individuals are involved, different population is involved. But very importantly, these metacarpophalangeal joints, they are involved more commonly than the metatarsophalangeal. That is the important lesson we should get from this. Now come here. This knee, regarding this knee joint, 30% of the patient, they may show early involvement with the knee, and 90% of the patient they show involvement once the disease become chronic. So these 30% patient, they may be involved earlier in the disease, and of these 30% patient, most of the patient, they comes from the LoRa group. What is this LoRa? Late onset rheumatoid arthritis. So the important thing is what? 30% of the patient with rheumatoid arthritis, they may show a knee involvement in the acute phase or the early phase of the disease, and of this 30%, most of the patient they comes from the LoRa group, late onset rheumatoid arthritis. Then what is this late onset rheumatoid arthritis? We called it as a late onset rheumatoid arthritis if it is occurring in the individual of a 60 years of age or more than that. Okay. So the rheumatoid arthritis, if it is occurring in an individual in 60 age group peoples or more than that, then we called it as a late onset rheumatoid arthritis. And in this late onset rheumatoid arthritis, this involvement of the knee in the early phase of the disease is very common. So the important thing is where the disease is actually started. So chances of us beginning of the disease is more common with this joint, and the chances of the involvement of the joint is concerned, the chances of the involvement of the joint, they can involve any of these joints in the late phase of the disease. And these are the joints which are most of the times unaffected or most commonly excluded joints are which? This distal interphalangeal joint, lumbar spine and the sacroiliac joint. These joints are mostly spared or mostly not affected in the rheumatoid arthritis. So very importantly, which are the joints which are involved first, which are the joint which shows late involvement, then we have also seen which are the joints when we are talking of the early involvement of the joint, which are the joints which are most likely to be affected, MCP versus MTP we have seen, where we get more chances of development of the damage to the cartilage and the bones in the MTP because of the weight bearing there. And this late involvement, if you see, the figures are almost been a same one. Okay. So with this information we will try to go further. Now here we will see now various deformities those we get in the rheumatoid arthritis. We have already learned that in rheumatoid arthritis there is a massive destruction of the cartilage and the bones which leads to various kind of deformities. So we will see this first deformity here, what we call as a SWAN neck deformity. So see the features of the SWAN neck deformity. In the SWAN neck deformity, we have a hyperextension of the proximal interphalangeal joint. So this PIP, proximal interphalangeal joint, is getting hyperextended. There is a hyperextension of the proximal interphalangeal joint, or we call as a bends backward. So by this joint it bends backward. And second thing which we get with a SWAN neck deformity is a flexion of the distal interphalangeal joint. So we are getting a hyperextension of the proximal interphalangeal joint, and also we are getting the flexion of the distal interphalangeal joint. And this variation, it gives a characteristic S shape which looks like a outstretched neck of the swan. So why we call it as a swan neck deformity? Basically because this variation it gives a H shape and it looks like a outstretched neck of the swan, and that's why we called it as a swan neck deformity. And along with rheumatoid arthritis, we get this deformity in the traumatic injuries also, and in a lupus also we can get this kind of deformity. This we have a first phalanx, this we have a second phalanx, and here we have a third phalanx. For the joint between the first phalanx and the second phalanx we call as a proximal interphalangeal joint. Here this proximal interphalangeal joint is showing hyperextension, So here we have a hyperextension at this joint, proximal interphalangeal joint, and this joint between the second and the third phalanx we call as a distal interphalangeal joint, which is showing a flexion. So here we have a flexion of this joint, and here we have a hyperextension of this joint, isn't that? So it will like this. This is a finger here, and this PIP, it is a bending backward hyperextension, and this is bending forward. This interphalangeal joint bends forward. So this it is this here it is giving looking like a what we call outstretched neck of the swan, and that's why we call this as a swan neck deformity. And this deformity we also get in certain kind of traumatic injury. Other than RA, we can see the deformity in various kind of a traumatic injury, as well as with the as well as in the lupus. So we'll see now a few images so that our concept will be more clear. Now look here. This we have a first phalanx, this we have a second phalanx, and this we have a third phalanx. So first phalanx, second phalanx, and the third phalanx. The joint between the first and the second phalanx we call as a proximal interphalangeal joint, whereas the joint between the second and the third phalanx we call as a distal interphalangeal joint. So here we have a proximal interphalangeal joint which is showing hyperextension. Okay, so here this proximal interphalangeal joint, it is getting it is bending, it is showing hyperextension there, that is a bending backward, whereas this distal interphalangeal joint is showing a flexion. Okay, here it is showing a flexion, and this picture it is looking like a outstretched neck of the swan. So here we have a hyperextension of the proximal interphalangeal joint, whereas here we have a flexion of the interphalangeal joint that gives a look of a outstretched neck of the swan, and that's why we call this deformity as a swan neck deformity. Now look at this image. Here this pictures here, it is clearly showing this swan neck deformity. You can see here there is a hyperextension at the proximal interphalangeal joint, as well as there is a flexion of the distal interphalangeal joint here. You can see here also there is a hyperextension of the proximal interphalangeal joint, whereas there is a flexion of the distal interphalangeal joint. Same thing you can see with this finger here. There is again been a hyperextension and the flexion here. So this swan neck deformity, with this picture I think your concept will be more clear. So see this image here, there is again been a hyperextension of this proximal interphalangeal joint, and there is a flexion of the distal interphalangeal joint, which is matching with the picture again of a swan neck deformity. So this swan neck deformity is a very common feature with this rheumatoid arthritis, and it occurs in the chronic stage of the disease. Now we will see the next deformity, that is a Boutonniere's deformity. So in the Boutonniere's deformity, there is a permanent flexion of the proximal interphalangeal joint. In the Boutonniere's, there is a permanent flexion of the proximal interphalangeal joint, that is a bend towards the palm. So this joint is a bending towards the palm. Now permanent means this whatever the changes we have seen with the swan neck deformity or this Boutonniere deformity or any other deformity, they are almost been a permanent one, Even though I have mentioned that this word permanent here, this is true for the SWAN neck deformity also. Okay, so there is a permanent flexion of the proximal interphalangeal joint, and there is a hyperextension of the distal interphalangeal joint. There is a hyperextension of the distal interphalangeal joint, that is bent backward. And this deformity, it looks like a finger passing through the buttonhole, and we get this deformity with a RA and also with a traumatic injury. Here, see here, this image above, it is concerned with the Boutonniere's deformity there, and here at the this below image here is showing this SWAN neck deformity. So this image above and this image below, if you compare this image, they are almost exactly opposite to each other. Here this Boutonniere's deformity, as we have mentioned there is a flexion here at the proximal interphalangeal joint, and there is a hyperextension here at the distal interphalangeal joint. And in the SWAN neck, we have seen that there is a hyperextension at the PIP and there is a flexion at the DIP. Okay. So these two things here, they are exactly opposite to each other. This Boutonniere's deformity and this SWAN neck deformity. If you compare this flexion and the extension, it is occurring exactly in a opposite way. So we will see a few images of Boutonniere's deformities. See here, this we have a first phalanx, here we have a second phalanx, and here we have a third phalanx. As per the definition, there is a flexion at the proximal interphalangeal joint. So you can see there is a flexion here at the proximal interphalangeal joint, and there is a hyperextension at the distal interphalangeal joint. So flexion at the proximal interphalangeal joint and the hyperextension in the distal interphalangeal joint. So see here, you can see here, this is the first phalanx we have, this is the second phalanx, and this we have a third phalanx. That means this has been a proximal interphalangeal joint and this is a distal interphalangeal joint. By definition, we have a flexion in the proximal interphalangeal joint. So you can see here, it is flexed here, there is a flexion at the proximal interphalangeal joint, and there is a hyperextension here at the distal interphalangeal joint. Similarly, here we have a proximal interphalangeal joint here, and here we have a distal interphalangeal joint. At the proximal interphalangeal joint, we have a flexion here, and there is a hyperextension at the distal interphalangeal joint. So with these two images, I think that the concept of the Boutonniere's deformity is clear in your mind. Now we will see the next deformity, that is a subluxation. So in a subluxation, there is a partial dislocation of the joint caused by chronic inflammatory destruction of the ligament, bone and cartilage. So in the subluxation, we have a partial dislocation of the joint, and this we are getting because of the chronic inflammatory changes. So in RA, we know that there is a chronic, this RA is a chronic inflammatory disease where there is a destruction of the cartilage and the bone, and this process is giving rise to the subluxation. And there is a common involvement. The commonly involvement joints are joints of the hand and feet. So these joints of the hands and feet, they are commonly involved with this subluxation. And this cervical spine involvement is considered as a most critical one. Okay, so this if there is a cervical spine involvement, then the complications are more, and the commonest involved joints are joints of the hands and feet. So we will see one image with the subluxation. So this we have the image of the hand or X-ray of the hand here, and in this X-ray you can see at this metacarpophalangeal joint there is a subluxation here. So in this image there is a subluxation at the metacarpophalangeal joint of the thumb. So because of the damage to the cartilage and the bones and the ligaments, this metacarpophalangeal joint is showing a subluxation. Now here we will see the one more deformity, that is ulnar deviation or the ulnar drift, and definition wise progressive hand deformity where the fingers bent abnormally towards the little finger at the metacarpophalangeal joint. So in this deformity the fingers bend abnormally towards the little finger at the metacarpophalangeal joint, frequently accompanied by a wrist bending in the opposite direction. Okay, so there is a finger bending of the fingers towards the ulnar side, and the bending of the wrist towards the radial side. Okay, so bending of the fingers towards the ulnar side, whereas there is a bending of the wrist towards the radial side, and difficulty in making a fist or a straightening of a fingers. So in this deformity there is a difficulty in making the fist as well as straightening of the finger is very difficult with this deformity. So we will see the image of the ulnar deviation or the ulnar drift, so that your concept will be more clear. Now see here, this is the X-ray which is showing ulnar deviation, and you can see here this we have this metacarpophalangeal joints, and at this metacarpophalangeal joint the fingers they are deviated towards the left side. There is a ulnar deviation we can clearly see in this X-ray here. Then we will see this image here. You can see here now there is a at the metacarpophalangeal joint, these are the metacarpophalangeal joint, and there is a deviation of the fingers toward the ulnar side. Again here we have a X-ray, there is again been a deviation of the fingers on the ulnar side. In this image you can see all the deformities which I have seen. So here we have a SWAN neck deformity. First of all, you can see here these fingers they are showing SWAN neck deformity, that there is a hyperextension at the proximal interphalangeal joint, and there is a flexion at the distal interphalangeal joint, and as well there this thumb it is showing a BOUTONNIERE deformity where there is a hyperextension. Also it is showing ulnar deviation. You can see this ulnar, this is the metacarpophalangeal joints we have, and there is a ulnar deviation at the metacarpophalangeal joints. So all the three deformities we can see here in this image very clearly. So already in the definition we have seen that rheumatoid arthritis is a systemic disease, and in addition to involvement of the joint, it also involving various other systemic tissues also, and here we will try to see which are the extra articular involvement of the rheumatoid arthritis. So see here, In the rheumatoid arthritis, we get xerostomia, that is a dryness of the mouth, and xerophthalmia, that is a dryness of the eyes, as a secondary Sjogren's syndrome. Here, these two things, xerostomia and xerophthalmia, are getting because of the lymphocytic infiltration. Basically, these CD4 T cells they enters here, and these immune cells they cause the destruction of the glandular cells of the salivary glands and that of lacrimal glands, and it leads to decrease in the quantity and quality of these secretions, and thereby we are getting xerostomia and the xerophthalmia. Sometimes it is autoantibody mediated also. Then next is a pleuritis and the pericarditis. This we are getting because of the we know that these autoantibodies which are formed, they directly attacks these pericardial tissues and these pleural tissues, thereby inducing the inflammation there, and because of that we get pleural pains and pericardial pains. And also there is a damage to the endothelial cells sometimes also, and because of the damage to the endothelial cells it leads to the oozing of the fluid from the capillaries, and it leads to finally to the pleural effusion or a pericardial effusion. So this pleuritis and pericarditis we may get with a effusion also. Then next is a subcutaneous nodules. These subcutaneous nodules we are getting here because of the vasculitis. This vasculitis leads to the granuloma formation, and this granuloma we can feel as a subcutaneous nodules. And this interstitial lung disease. We have seen that in the lung hypothesis of the rheumatoid arthritis, the antibodies are formed against the citrullinated proteins in the lungs, and these antibodies they attack these citrullinated proteins, and because of that a chronic inflammation is formed in the lungs tissues. And because of the chronic inflammation, these epithelial cells, alveolar epithelial cells, they are converted into the mesenchymal cells. These mesenchymal cells they cause a pool of a myofibroblast, and these myofibroblast they secretes plenty of a collagen there, and finally these fibrotic changes develop. So these lung tissues are getting converted into the fibrotic tissue, thereby inducing interstitial lung disease. So all these extra-articular manifestations, some few more extra-articular manifestations are there, but just I have considered this important one and commonly seen extra-articular manifestations.